Okay, so we've spent quite a bit of time talking about things that we have control over as technologists that influence the image and the quality of the image, the quantity of photons that we're using. We've talked about geometric things that we have some control over when it comes to positioning the patient or the projection that we're using with the X-ray tube. Now we're going to talk about stuff that we don't have any control over, all right? Because we're going to talk about patient conditions, what the patient walks into the exam room carrying with them, and the ways that we're going to need to compensate for those as we're thinking about technique in the final image. So here's some objectives for us. First of all, I want us to illustrate methods for varying technique based on part thickness. And I'm going to deviate some from our textbook. I don't necessarily believe that this textbook is the Bible. There are some things about it that I think I can kind of take or leave. And there is quite a bit in this chapter that's more in the leave area. It is helpful stuff. He does present a very scientific method for approaching controlling for patient thickness, but I'm just going to give you kind of a one golden standard that will be useful to you, right? And this is something that will be helpful in terms of applying for different technique adjustments, particularly as it relates to body habitus, right? So we'll look at those first few pages of the chapter closely. Finally, secondly, we'll talk about the minimum change rule. It's not quite set in stone the way that the 15% rule is set in stone. I mean, the 15% rule will be on your registry, right? This minimum change rule is still kind of out there, kind of set in styrofoam, you know what I mean? It's not quite the creed, but it's pretty darn close to it, and it is something that if we memorize it, it will pay dividends as you're setting technique. It's a helpful thing to know. So we'll state that minimum change rule, and I will be testing you on the minimum change rule, okay? We'll also talk about the effects. So we'll change gears a little bit. We'll move from part thickness into a discussion of molecular composition, right? And that may sound fancy and scary, but really I'm just talking about 5 different basic materials that have an influence or show up on the X-ray images. He outlines that in the chapter. And the final part of this discussion that the patient kind of brings into the exam room with them is their pathology, right? And what we know is that there's some pathologies that we'll consider additive, meaning that they add something to, we have to have additional technique to see those pathologies, and then there's some pathologies that are subtractive. We need to actually reduce technique in order to see those pathologies. And there's kind of 2 special cases there that we'll look at briefly. Those are techniques for soft tissue radiography. Has anyone done a soft tissue neck yet? Okay, so a few of us have seen that. It is a different technique that we set for that. And the AEC is not always helpful for that technique. So it is helpful to know how to set that technique. And then we'll also talk about techniques for x-raying casts and splints, which hopefully you'll be able to use some at Campbell's, you know, this summer, other orthopedic places this summer. So part thickness. We do not need to memorize this table on page 285, but it is helpful, and this comes from a whole lot of work that the writer did looking at people throughout the United States of America and coming up with an average part thickness. Now we might be wondering, why on earth is that helpful? Well, when we talk about body habitus, I'll give you the second reason that it's helpful, but the first reason that it's helpful is if I know the averages, right, then I can, the variations to technique that I need to make will generally either a standard deviation above that average or below that average, right? So I'll either be increasing the technique above the average or below the average. Anything within the average, I can use a pretty standard technique. So while we don't need to memorize these averages, it is helpful to see how closely they all relate, right? So if we're dealing with hands, wrists, forearms, and elbows, we're talking about something in the range of like anywhere from like 3 to 8, what is that, centimeters or whatever? Yeah, in centimeters. And it's helpful to always see how the lateral is typically bigger, right? So those are the 2 takeaways I would take from that chart, is that knowing, you know, how the parts range, and if you were to think about, if you were to map these techniques onto some of what these measurements into some of what you're seeing in the clinic, you would see that as this body part thickness increases, in general mass increases as well, right? That's what's being demonstrated here. So part thickness, a measurement of part thickness is going to give us the most systematic and scientific way to approach radiographic imaging. And the way that I've asked us to approach part thickness, what he talks about is making caliper measurements. I've asked us to approach it using a measuring tape, right? I think that we're more likely to continue with that practice in the clinic and it be beneficial to us than walking around with calipers sticking out of our pockets, right? That would just be crazy. One thing in thinking about how to employ the measuring tape is it needs to be basically measured at the point in which the central ray hits the body. That's the thickness that we're interested in. So we want the measuring tape to basically traverse the direction and area that the central ray is traversing, right? So we're basically measuring the distance that the central ray has to traverse the body. If there's an angle on it, whatever, we need to measure it along that angle, right? So that we understand the distance that the central ray is traveling. Again, most patients fall within an average range of thicknesses. And so it may be helpful to have something like this right next to the technique chart on a portable machine to know that the average range of thicknesses is this. So if I measure the body part and it's above that average, I know I need to bump up my technique, right? The way that I would adjust the technique then, and this is effective, and it is something that you'll definitely want to come back to and revisit when it comes to the lab where we're constructing digital technique charts, because this is kind of the name of the game for that lab, is the 4 centimeter rule, or you could also think about the 1.5 inch rule, is that for every 4 centimeters or every 1.5 inch change in part thickness, we'll need to adjust the technique by a factor of 2, right? So if I measure, for example, I'm doing for some reason on the same patient a hand, and I'm also doing the elbow, right? And the hand measured at a 4 centimeter thickness and the elbow measured at an 8 centimeter thickness, I know that I'm going to have twice the mass from the hand to the elbow. So I already know what the elbow technique is if I have the hand technique. In essence, what this is saying is if I know what a hand technique is on this machine, I can compute technique for any other part of the body. That's a good power to have, right, as a technologist. But if I know I can shoot a good hand x-ray, because that's the minimum amount of patient dose that I could have. If I have a technique for a hand x-ray, with the 4 centimeter rule, I can calculate what the technique should be for the rest of the body, right? So as you're walking in to do that lab, where we're actually having to calculate a digital technique chart and produce a digital technique chart, it's going to be really important to figure out what that hand technique is, right? Because if I have that, I can figure out the whole rest of the lab like that, just by applying this rule. That is the case for part thickness. Let's talk a little bit about body habitus. So this is kind of a subscript to part thickness. I'm going to zoom in some on this image. So what's interesting is, I don't know if this is still the case because it looks like this drawing was made prior to what we now call the obesity epidemic, but it says that sthenic, which is average or healthy, accounts for 50% of the population. So they are, again, the average body thickness is going to be based on the sthenic patient, and so all technique charts are based on the sthenic body habitus. So if you're looking at a technique chart and wondering, okay, how do I vary this? Just know that it is directly tied to that sthenic body habitus, right? The other thing that's helpful, I think, about this illustration is there's some mnemonics that help us remember this, like stout, and I think it's thick and stout, or short and stout, up and out, tall and thin, down and in. What that's describing is the location of the gallbladder based on someone's habitus, right? So I can draw that here. I'll draw it in green. So I said short and stout, up and out. So the gallbladder, here's that, that flexure there, and I would expect the gallbladder to be kind of on this side of the flexure. So the gallbladder is up and out, right? Tall and thin, down and in. Again, I would expect the gallbladder to now be down in here, right? It's moved down and it's moved closer to the midline, right? If I know where the gallbladder is, I know where the liver is, right? If I know where the liver is, I can start to put together all sorts of things. I know roughly where the diaphragm is at, right? So being able to remember that mnemonic will be helpful, especially if I'm thinking, okay, I'm trying to shoot an AP chest x-ray on this person, probably need to have the cassette-oriented portrait style, right? Because the diaphragm is going to be that much lower, right? And a lot of times, too, with this type of person, we even start to see apices that are like up here near the odontoid or something. It's crazy on that habitus, right? Some of the stuff that happens with the lungs. Versus if I'm shooting the same AP chest x-ray on someone that's a hypersthenic body habitus, I probably need to have it landscape oriented because the lungs are going to be compressed up because, again, that gallbladder is up and out, right?
So hypersthenic is short and stout, up and out.
Mm-hmm.
And say the other one again?
The other one is talking about, and this should have an A in front of it. I'm just now noticing that. Asthenic, sorry, that's the error there. To describe asthenic, it would be, what is it, tall and thin, down and in. Tall and thin, down and in, describing the location of the gallbladder. Now, if you're wondering like what these different habituses are describing and the Latin's kind of throwing you off, just remember that sthenic means normal. It means average, it means normal, it's 50% of the population, right? If I'm above normal, I'm hypersthenic, so that's heavier than normal is what that means, heavier than normal, right? Hyposthenic means, right, just like I'm trying to think, hypostatic pressure or something like that, less than normal. Hyposthenic is less than normal. Asthenic means it's not normal at all, right? Anytime there's an A in front of something like that, it means abnormal, right? So it means this person's very, very, very sick, very emaciated, okay? Now he does add a fifth body habitus to this. Does anyone remember what it is? It's Arnold Schwarzenegger, basically, right? It's large and muscular. So in this case, we have someone who is very, very muscular, and that additional muscular tissue has more density to it than fat tissue. Fat tissue is closer to water in terms of its molecular composition. So that added tissue density, as well as the added blood and stuff flowing through that tissue density, causes us to need to increase technique, right? I'm not going to get all into the argument of that. It is just helpful, just know that it's helpful to know these classifications of body habitus and the ways that they can influence setting up for a technique as well as the actual technique itself. So with that being said, let's talk about this minimum change rule. This is on page 286 in our textbook. When an exposure needs to be adjusted, the minimum change that should be made is 35% change in the mass or 5% change in KVP. 35% change in mass or a 5% change in KVP. Just memorize that. It's saying that, I don't know, going back to Campbeller's discussion of Touch Tech 2018, if Touch Tech 2018 is not changing my mass by more than 35% of what I've set, then that's a pointless change. It's a completely pointless change. And honestly, Touch Tech would have heard that at some point in time because this rule has been with us for a long, long time, right? So this tech even knows that in the back of their mind. So a lot of times if they do vary it, they'll vary it right back because they'll vary it and they'll remember, oh wait, that minimum change thing, and they'll put it back down. Because they just realize it doesn't matter. Unless I'm going to change it significantly, like 35% or more, there's no reason to change it. Now the reason I say this rule is kind of set in styrofoam, not set in concrete, is that it had a heavy impact on film imaging. You could literally sit and watch these changes happen on a film system. They are not as influential on digital, right? But the rule stands. It is a helpful rule, and it is generally considered the minimum change that's going to be visible on the image, right? Okay, I'm going to change gears now. And were there any questions about minimum change? We good on that? Okay, let's talk then about molecular composition. So I am moving through this chapter pretty quickly. And you can see there's quite a bit that I've kind of tossed by the wayside. I am not interested in talking about anthropological factors like measuring someone's skull size, right? I don't necessarily think that we need to dwell a lot on the influence of age, right? Some of this stuff is kind of old school, and a lot of it's being already controlled for by the machine. But the next thing that is helpful to consider is molecular composition. There are basically 5 material types, or 5 types of molecules that show up with appreciable linear attenuation coefficient differences, or visible differences, on an X-ray. And that's for single energy X-ray, I should emphasize. He doesn't say that, but I'm talking about single energy X-ray. And those are gas, fat, liquids, bone, and metal. Gas, fat, liquids, bone, and metal. All right? If I was using a dual energy system, I would just kind of have to toss that out the wayside, because there's going to be a lot more appreciable differences using dual energy. I would be able to differentiate between, is that kidney stone primarily calcium, or is it primarily something else? So I'd be able to make much more, at a much more concentrated level, be able to make molecular determinations. But for the general X-ray, general diagnostic X-ray, those are the 5 things that we're able to appreciably notice differences in. Now, that is helpful to us, particularly if we're using contrast, because it's helpful to know why positive contrast works the way it does versus why negative contrast works the way it does, and they work differently. Right? They work differently. I guarantee you're going to see this again somewhere. So just remember that they work differently. Positive contrast appear radio opaque. That's the fancy word for it will appear white on the image. Positive contrast will appear white on the image due to its high Z number. It is more like a metal, is what that's saying. In fact, that's one of the reasons that we use iodine-based contrast, is iodine's metalloid in type. It is closer to a metal on the periodic table. In fact, he goes into how it's 5 times the molecular density of blood, or 500 times, I think is what he says. So it results in a significant change in attenuation of the X-ray beam if we have iodine contrast in the bloodstream, right? Interestingly enough, if you think about it, if it's absorbing more X-rays because there's iodine contrast in the ureter or in the bloodstream, guess what? It's also increasing patient dose. So anytime we're using positive contrast, we are also increasing patient dose. And we can calculate the amount that we've increased patient dose, in fact. So that is because of photoelectric effect and the fact that it has an increased Z number, right? Negative contrast agents do not work on that basis. Negative contrast agents appear radiolucent. That means that they appear black on the image because the X-rays are able to pass through it due to low physical density. So one has to do with atomic Z number. The other has to do with the fact that if I have gas in my lungs, if I have air in my lungs, that lung tissue is physically less dense, right? It has gas in it primarily. So it could float on water, if you will. If we were to get down into the weeds with this, we would realize that it can't be because of Z number, because oxygen has a higher Z number than water, right? Oxygen has a Z number of something like 6, I think. I can't remember if it's 6 or 8 off the top of my head, but it's in that range, versus water has a Z number that's closer to hydrogen, right? 2. So it can't be because of Z number, right? It has to be because of physical density. So, but these molecular composition questions are important. Okay, I'm changing gears yet again, and this is really our third and final thing that we're going to talk about in terms of what the patient walks into the exam room having. It is their pathology, right? There are certain pathologies that we will consider additive and certain that we will consider destructive or subtractive, meaning just how we have to change the technique. So for the most part, I would encourage people just to memorize these. I don't know which one's going to be on your registry, but I can pretty much guarantee you that one of them is going to be on there. We will drill down into this more when it comes time for comparative pathology, because it's a central concern of comparative pathology in the fall. But it is one of those times where it's helpful if you had some Latin in high school, or if you did really well in medical terminology, because this goes back to those Greek and Latin stems, right? Prefixes and suffixes and stuff like that. So mega, anytime we see the word mega, it means something's bigger or more, right? So acromegaly, it's a no-brainer then. If there's more of it, it's going to be an additive pathology, right? Then there's stuff that we just have to remember, like fibrous carcinomas and ascites, right? So knowing some Greek and Latin will help you figure a lot of these out. Knowing some A and P will help you figure some of them out, right? Like cirrhosis. Anytime a person has cirrhosis, it causes enlargement of the liver. Therefore, that's additive. I need to increase technique if I'm doing an admin on someone who has cirrhosis, right? Anytime in general I see something that suggests there's a fluid buildup, like hydropneumothorax, or I'm trying to see another, pleural effusion, anything that's going to cause a buildup of fluid, additive in nature, right? So I'll have to increase my technique. Some of these, I think the hardest ones, in all honesty, are the osteo stuff, right? The bone stuff, because some bone stuff is additive and some bone stuff is subtractive, and it's sometimes counterintuitive, right? So osteoarthritis is considered additive because it causes increased amounts of junk in the joint space, right? That's not the medical terminology for it, but that's basically what it's doing. Osteochondroma, in a similar way, it's a bony tumor that's going to add mass to the bone, right? Osteopetrosis literally means stone bone. So if I've got bones that are like stones, it's definitely going to cause an additive thing. And one way you can remember that is Jesus called Simon Peter, right? And he said, "On this rock I will build my church." That's what Peter's name is. Petra means rock. So it's right there in osteopetrosis, right? That comes right from the Latin for rock. Subtractive pathology. I would just follow the minimum change rule in this case, right? So follow the minimum change rule if we're talking about subtractive pathology. For the others, I think it's a 15% increase in KVP. Okay. Anytime we see blast, right, probably means something's being destroyed. Lytic means something's being eaten through, right? Septic means that there is some kind of infectious process going on. All of those things erode normal tissue, right? So necrosis, septic necrosis, blastomycosis. I think one of the most counterintuitive ones is bowel obstruction. So walk through this one with me, all right? If a person has a bowel obstruction, what happens is, if you can imagine, you were blowing up a balloon and now you tie the balloon, right? That's what a bowel obstruction is. It's the tied balloon. So it's holding gas in the bowel. It's not that there's so much crap in the bowel that they're obstructed. It means that somewhere there's enough to cause a blockage, and now the bowel is just producing gas on end. These are the people that are so backed up that they come into the exam room and they're burping, right? Like Shrek says, it's better out than in. That's what's going on in their bodies. So it is inflating, it's insulfating the entire digestive tract with air. So bowel obstruction to me seems counterintuitive, but it is subtractive because we just increase the amount of negative contrast throughout the digestive system. Gout is another one of those that I feel like is counterintuitive. It does cause destruction, but it causes mineralization as well. So I have to just remember that the destruction is more than the mineralization. And then here's the osteos on this side. The osteomalacia, osteomyelitis, and osteoporosis, I think those things just have to be memorized. Osteoporosis, I can kind of reason through, that makes sense. But the other two, I just kind of have to memorize. Pneumothorax, so if it's not a hydropneumothorax, if it's a pneumothorax, meaning that there's air trapped between the pleural viscera, then yes, it will be subtractive in nature. I'll have to reduce technique. Okay? And then finally, rheumatoid arthritis. Okay, here's the last point of discussion, casts and coughs. Anytime we are dealing with a foreign body survey, or we're trying to find something tiny that the patient has swallowed, or we're evaluating soft tissue structures, generally just in the neck, we're going to need to increase subject contrast. And to do that, we're going to decrease KVP by about 20% without changing the mass at all. So we're going to get something that looks kind of underexposed and hazy. The bones will be crap, right? But you'll literally be able to see muscle tissue now, and maybe even some major vessels on that exposure. The bones will be noisy, but all of the soft tissue structures will be good. So about a 20% decrease in KVP without changing the mass. It's a strange technique. Finally, casts and splints. Most casts that are used now are fiberglass, and they require just a standard technique. You don't have to worry about it. But if for some reason you're at a facility that's still using plaster, or a plaster and fiberglass blend, the plaster casts basically require about a double mass exposure, especially if the plaster is still wet. So if they just set the bone, they want to make sure that it's set appropriately while the plaster is still wet, you'll probably have to double the technique from your normal, right? So it's important to ask them, what kind of cast material did you use? And change the mass accordingly. If it's a fiberglass and plaster mix, you can use about a 50% increase in the mass alone. We would not want to increase the KVP on those. We would just want to increase the mass in that case. Okay? Because increasing the KVP would just increase the scatter coming off of that plaster material. Okay, so just increase the mass. One other thing that we could probably sandwich in there is, you know, the all-you-can-eat buffet special that we sometimes have to do, right, portably. Those in general, we want to drop the KVP. Like if I'm shooting a bariatric patient, that's what I mean, like 400, 500 pound AP chest x-ray. Ironically, I probably need to drop my KVP and increase the mass a whole lot, right? And definitely use a grid. The reason that I'm doing that is the KVP, again, is just increasing the scatter at that point. As long as I've got sufficient KVP to penetrate the anatomy of interest, all that needs to be increased is the mass, right? So I would apply a grid factor, and we'll talk about that next week, and then add some mass in addition to that. Okay?